So I'm with Tim Leiner from Utrecht University Medical Centre. What has been your highlight of the conference?
So the highlight for me was definitely the session on machine learning and the options that come out of this technology for doing better, quicker and more comprehensive CMR.
So what is deep learning when applied to CMR?
So I think deep learning is, the way you can look at this is a set of tools that can basically optimize some of the steps we do today, but that applies to the entire image acquisition process, reconstruction process, but also, and that is what most people associate with deep learning, is the interpretation of images. And I think today we've seen that deep learning methods are very powerful, for instance, to get rid of some of the more tedious tasks in CMR, like drawing circles to determine ejection fraction. But eventually these things can do many more tasks and perhaps also suggest a diagnosis or to shift people to a normal category, and then you can pay attention to the patients who actually have disease. So think about those things as well.
Do you see this as being becoming bigger and bigger as we go forward in CMR over the next few years?
Definitely. So this is going to be really big, and but the question is, or the effort should be aimed at identifying, let's say, useful things for these algorithms to do. Many people are working on the development of such algorithms, but I think it would be good to team up with developers to make sure that they work on clinically relevant questions.
What do you think are the barriers to getting this into kind of routine clinical care?
So I think the barriers reside mainly in getting these algorithms approved by the authorities for clinical use. One of the barriers is that these are algorithms that can change over time because they learn new things. And that's not the way authorities like the FDA or the European authorities look at these algorithms. They look at this as a fixed algorithm that does a certain task. But if you work with deep learning algorithms, these things can change over time. They become better, so if you do it right.
I see. Okay. And just moving on to gadolinium, I know there's a lot of debate around gadolinium.
Yes.
What are your views on the latest understanding and guidelines about gadolinium?
So I think we're beyond the era of NSF. So we know that certain agents are associated with long-term deleterious consequences like NSF, and we know how to deal with that. In the past couple of years, there's been more attention to acute adverse events of gadolinium. So although the frequency of those adverse reactions is very low and they are generally very mild, sometimes you can run into a patient that has an acute allergic reaction that demands immediate treatment. So that's a thing to be aware of. And of course there's the issue of retention of gadolinium in the body, to which the authorities in the United States reacted differently compared to Europe, and they basically agree on the science, but they have different consequences right now. So the FDA has said, okay, we'll see how this develops, and the European Medicines Agency has decided to get rid of all the contrast agents that are not macrocyclic. And yeah, even though there's no real evidence yet that this causes harm in patients. So the observation of retention is an interesting observation, but there's no evidence yet that it's harmful. So.
In that regard, what studies do you think we need to do looking into gadolinium, perhaps regarding retention in the body?
Well, pertaining to cardiac MR, I think we should try to develop protocols that allow us to work with lower doses than we do today. So for instance, if you look at myocardial perfusion, that's typically done with 1.5 to double dose gadolinium injections. I think we should try to develop protocols that limit that to a lower dose. For instance, a single dose or maybe even lower. So that'll demand some work because we've developed the protocols that are very successful now with higher doses. And I think the entire field of MR is moving towards lower doses of injected gadolinium. Perhaps there are even some non-contrast techniques that can help us out. Yeah.
Okay, brilliant. Well, thank you very much for your time and enjoy the last day of the conference.
Thanks.